This is going to be a very kind of brief overview of what we've worked on. And really, obviously, the point of this is to allow people to ask questions and have a dialogue. And so, Stephanie, I guess you'll probably monitor the chat a little bit too. And if there's something that's apropos, then please don't hesitate to interrupt and get me to stop.
I will let you know.
Okay, let me see if I can advance the slide. There we go. Okay. Because I don't know all of the folks who are participating in this, I don't know at what stages of bladder cancer you have been diagnosed with, you or your loved ones or family members, but I'm going to focus mainly on radical cystectomy. For those of you who don't know, it's the operation for removal of the bladder when you have advanced bladder cancer. Oftentimes it's for muscle invasive bladder cancer. Or if there's non-muscle invasive bladder cancer that keeps coming back, then a lot of times your treatment team will say, hey, it's time for that bladder to come out. The problem, as many of you know, though, is that radical cystectomy is a really, really tough operation to get through. About 2/3 of people will have a complication sometime within 90 days. About a quarter of patients will actually have to get readmitted into the hospital. About a quarter of people, the complications are actually a major complication. And anywhere from 3, and some of the literature will say even up to 7% of patients will actually not make it 90 days. And I kind of mentioned at the bottom of the slide, ERAS is something that has really been promoted within the last, I would say, 5 to 10 years. It's enhanced recovery, and a lot of it has to do with how can we get people through surgery efficiently, effectively, and quicker. And you know, the thing that we have found is that yes, we can get people through surgery, you know, quicker. We can get them out of the hospital, but it really hasn't changed regarding the major complication rates or the readmission rates. And so really what we're wanting to do is see if we can change the biology of the treatment instead of just the surgical aspects or some of those things. So what our team, you know, I of course, you know, am biased, but I think that one of our strong suits at the University of Kansas is having Jill and the dietetics and nutrition teams and the folks that really lend a lot of information and are true partners in the treatment of these patients. And what we wanted to focus on is the nutritional factors. And you know, I'm not going to get into the weeds with all of these studies that I have on these slides. It's probably a little beyond what our discussion is, but this slide basically says that if you are malnourished, you're more than likely going to have a complication around the time of radical cystectomy. The one thing that I do want to focus on is the albumin, which is a protein in our bodies, and it can be a measure of our nutritional factor. And we all know who do this science that it's not a perfect test, just like a lot of tests just aren't perfect, but it is one of the markers of just kind of general nutrition. And so all I want you to take away from this slide is if you have low preoperative albumin, meaning that it's lower than it should be, you do have a higher overall rate of complications. In fact, this is another study that looked at different factors to define malnutrition. So again, that albumin comes out, so less than 3.5. The BMI, so body mass index, I think many of you are probably familiar with BMI. I think most of us want to get to that lower BMI, but as you know, when your BMI is too low, that's not a good thing. So less than 18.5 is very, very hectic. And then a preoperative weight loss of more than 5%. So if you're losing a lot of weight before surgery, again, that's not an ideal situation. And what this study found was that if you had any of these nutritional factors that were depleted or any of these factors, your mortality likelihood is much higher and your likelihood of survival is lower. And so that is really compelling evidence to say that nutrition is extremely important in outcomes for radical cystectomy. One of the concepts that we want to make sure that we portray and get across to everybody is that Just because somebody is obese does not mean that they can't be malnourished, though. And so this slide essentially says that even at these higher body mass index categories, which is considered obese and overweight, there is a certain portion of these patients that are also showing signs of malnutrition. And so that's really important to keep an eye on as well, too. Very, very similar slide. Again, the biggest take-home point, this is a lot of data on the slide. The biggest take-home point is it's almost saying that regardless of obesity, your serum albumin, so again, your marker of nutrition, is more important in regards to overall complications. And so what leads to malnutrition? When you're getting care, when you have cancer, dysgeusia is a term that we have really been kind of thinking about a lot, focusing on a lot. People who are undergoing chemotherapy oftentimes will have smell and taste changes specifically. You know, in fact, I've had people, and my partners have said the same thing, that even people who don't undergo chemotherapy actually will have taste changes. And so a lot of these factors will contribute to the fact that, and again, a lot of you out there may have already been through chemotherapy or are going through chemotherapy. Those taste changes and smell changes really are altered and really decrease your ability to get good nutrition. Additionally, if you have diarrhea or constipation, you can have poor intake of nutrients or malabsorption of nutrients. And so a lot of times, you know, I think we as, you know, I'm going to take the side of the patient, we as patients say, well, this is just a part of treatment and I just have to deal with it, or it's just part of treatment and let's just see. But there are actually ways to improve your nutrition even when you're suffering from these things. And there are tips and methods to really improve upon this. And that's part of what we really wanted to get across to patients. Furthermore, if you look at the guidelines for the treatment of non-metastatic muscle invasive bladder cancer, and this was put out by the SUO, the AUA, basically saying that we have a duty as clinicians to attempt to optimize patient performance status in the perioperative setting. And performance status is highly dependent on nutrition and overall health. So what we aim to do, where this project came from, was that we wanted to create a very systematic way of disseminating information through a video education series. And this is where Mugur is just a phenomenal investigator looking at really how do we get information across to patients? Because when I first met Mugur, I thought that videos were just, you take an iPhone, you walk around and you just record some information and then you give it to people, and that's how you teach somebody through video. But there's a lot of good science out there in terms of how you actually engage patients, how you actually study the engagement of patients. And so he's really introduced me to a world of video and education that I didn't even know existed. So we wanted to also have not just didactics and just somebody lecturing to somebody and saying, oh, here, you know, eat this, eat this, eat this. No, we wanted to have practical applications. We wanted to create recipes and how to make those recipes with, you know, demonstrations. We wanted to create about 4 to 7 episodes for each of the subjects we were going to focus on, about 3 to 5 minutes, because as you know, our attention spans aren't always the longest and you want to get things in bite-sized pieces. So we also wanted to, and again, this was terminology that Mugur really introduced me to, but emotion elicitation, audio and filming. So movie-like quality, and that really gives patients and the audience really, you know, they'll focus better and they'll get that information a little bit more effectively. So the script development, again, you know, my initial thought was, oh, you just write the script and you record, but really the important thing is that you've got to make sure that we use an iterative process, meaning that it goes through different levels. So we chose for the 3 video series, high protein nutrition, So we want to make sure we keep lean muscle mass and fuel and tissue repair after surgery, which is obviously very important. And then dealing with dysgeusia, so the altered taste from chemotherapy and other treatment, and then tips for managing diarrhea and constipation. So we had a team, actually, one of Jill's research assistants really worked super hard on writing the script, and then it got passed around to the research team. And so we picked at it, you know, we went through it multiple times. I don't know how many times it goes through the process of email back and forth, and down to each little word about, you know, we wanted to talk about specific things and get everything in a short amount of time. You know, we've got Mugur on the other end saying, hey, we can't record for 17 hours here. We got to cut this down into a certain amount of time. So we really went through the process and snipped it and cut it. And then we passed it on to an external advisory board of external nutritionists and dietitians who are experts in these fields. And then once we were done with that, we passed it on to our patient advocate partners, who obviously are very, very important in this process, because if they don't understand it and they're giving us poor feedback, then it makes no sense to them, then it doesn't do any good for us. So what we did was we did our video recording. Our actors were physicians, nutritionists, and dietitians, which, interestingly enough, one of the nutritionists, dietitians who is in the video that I'm going to share with you later actually has a background in acting. So we were very, very lucky to have that. Whereas the one video that I recorded, I had to read off a teleprompter because I am not an actor. So, but we had people from the research team, and we recorded this at the University of Kansas, the Clinical Research Center, in the teaching kitchen. So we had a great venue to be able to record these videos. Let's see. Can you give me the next slide, Stephanie? Yep. I apologize. I'm actually moving my face screen back and forth because I can't read parts of the slide when I've got it in a certain way. So sorry. So we do these video analyses, and this is the fascinating science behind it. And Mugur, you may want to chime in on this part, but we have a application. Do you want to chime in, Mugur? I feel like I'm talking too much. So why don't you chime in on this one?
I will. Can you hear me? Okay.
Yeah. Yep.
All right. So first of all, let me say how honored I am not only of participating on this seminar, which I think it's extremely important, but also being part of this extraordinary research team. And you know, the deliverables that you're seeing right now, it was just a common effort. So it's, you know, I'm so excited. So one of the things, you know, what we did, it's a combination of artistry with science, basically. Because after we got the scripts, and I still remember the first version of the script, it was so technical and scientific. Okay? And we took that script, and working together with Jill, with Heather, and with Gene, we actually took that narrative and more or less converted it in a story, you know? So we make it accessible, so we can deliver the information that's pertinent and accurate to the patient, but in a way that it's accessible to them as well. So after we're done with the script, then the next step was we filmed it. And here is where the artistry came, because we actually worked and we consulted with professional filmmakers. And one of the things that we did that Eugene mentioned a little bit at the beginning was we film in 24 frames per second. So just for you to have an idea what this technical thing means is that normally what we see on TV, our screens on the computer, they work at 30 frames per second, you know, sometimes at 60 frames per second. 24 frames per second, it's what we see the movies being filmed when we're going out on the big screen, you know, at a movie theater. And that 24, that difference of 6 frames per second makes everything more smooth and more accessible in terms of the image. So that's one of the things we did. So also we use a lot of cinematic tools and tricks, like we use shallow depth of field, we use camera movements, things that you don't usually see when you're thinking in terms of this is a professional video or a training video about nutrition in oncology. And also we try to avoid talking heads, the way I call them, as much as possible. So that was the science behind it. And of course we use lights and to create the mood and everything else. The science behind it is, okay, so this is how we want the message to be delivered. Let's see how good we can actually estimate how that information was delivered. So we approach it in two ways. One of them is we wanted to make sure that our narrators, the actors who are playing in our videos, because they were not professional actors with one exception that Eugene mentioned, they convey the emotion that we were looking for, okay? So for example, we want to make sure that Jill doesn't look angry when she's talking about broccoli, for example, right? So we use this suite that does what's called facial emotion recognition, okay? So we analyzed all the segments of the videos that end up in the final production to make sure that the emotion that is conveyed is a positive one, that body language, it's the correct body language, and not only the voice and the words, but also the way people act conveys the information that we're looking at and create that positive emotion. So that's was one of the things. Can we move to the next slide, please? In addition to that, we also wanted to make sure that the way we put together the videos and the way we're delivering catches the attention and the focus of the patients. So we did a study in which we use what's called eye tracking to really see where people are, what parts of the video people are paying attention on, and if they're not getting distracted by, for example, things that are happening in the background or for a flower that's there. And we want to make sure that the attention and the way we're conveying information elicitates a maximum or maximal engagement of the patients with the video. Can we get the next one, please? Okay, so here is something that you see that we did eye tracking, and then we analyzed where patients were looking as the narrative was ongoing, as the video was playing, where they were looking. And we combined this with a series of questions and metrics that we had, and we asked the patients at the end of this experiment. And it was very, very interesting because, you know, Eugene mentioned about making sure we have the attention focused for 3 to 5 minutes, and that's why we only had 3 to 5 minutes videos. But it was so interesting because on some specific topics, like for example dealing with constipation, some of the feedback that we got from patients were, oh, we wanted to know more about it. We actually wanted a longer video, and that's why we have a series. So each of the 3 topics that Eugene mentioned earlier has a series of videos, and it's a combination between instruction and education videos with cooking demonstrations. And when it came to cooking demonstration, we didn't want you to feel like you're in a clinical setting. We want you to take you outside of it and put you in a cooking show, okay? Think Rachel Ray, right? That was the kind of emotion and feature we want to convey. So we film accordingly in order to do that. So this is the production part and the testing of both the production, the delivery, and the impact that the videos had in our patients. Thank you.
So I'm just going to say that toward the end of the program, we're going to show you the web page where those videos are housed, and then I'm going to ask a question later on. So we'll be able to get to that towards the end of today's program. Go ahead, take it away, Dr. Lee.
All right, great. So I'm going to kind of move a little bit quicker through this part. A lot of this was Heather's portion of it too. But coming up with knowledge questions, we wanted to make sure that we include knowledge questions to make sure that people are understanding the information that we are trying to deliver. And so we did the same thing with this. We went to an advisory board. We wanted to make sure our questions, they were relevant, they were clear, that they were at an appropriate reading difficulty, and that we would revise or delete poor items. This was also currently being undertaken with semi-structured interviews as well too. And the reason I say currently undergoing is because obviously with COVID, our people interactions had to be cut out, and so we had to change our process into being able to do things through Zoom and telephone visits. But again, these questions are not implemented in the videos yet because we are still trying to test them with patients right now. And so that's still an ongoing process. This again is the survey revision process. We developed the ideas or the questions. We wanted to make sure that the expert content review was good. And then cognitive interviews with target audience. Again, that's where we are right now with active recruitment. But again, it's been difficult because of COVID. So what I do want to do is actually just go ahead and show you one of our videos, and then I'm going to open it up to questions. And I think that's where probably Jill is going to have the most impact because she is actually the content expert for the nutrition component. So I know that everybody's probably writing a bunch of questions that only she can actually answer. So I'll turn it over to her. But